Good afternoon, everyone. Our next topic is the physical examination of the eyes and the oral cavity. So, um, we're going to start first with the physical examination of the eyes. These are our two topics for today, the basic eye exam as well as the oral cavity examination. Let's start first with the basic eye exam. Let's review quickly the anatomy of the eye. So, the eye has three layers: the fibrous layer, the vascular layer, and the neural layer. So it is also known as the fibrous tunic, a vascular tunic, and neural tunic. For the outermost, remember that the eye is a globe. So it's like this. Okay? So the outermost layer is composed of the sclera. In Filipino, the puti ng mata. While the cornea is also part of it. The cornea makes up the majority of the refractive power of the eye, around two-thirds. Next is the vascular layer. So the vascular layer is composed of the iris, the choroid body, which provides or synthesizes the aqueous humor, and the vascular layer, meaning the blood vessels go through here. And lastly, the neural layer, which contains the retina. Just like our other topics here, the eye exam could be divided between the history and the physical examination. Okay, so we're going to start first with the history. Then we're going to tackle some of the more common signs and symptoms that involves the eyes. And lastly, the basic eye exam could be divided into three, and I want you to memorize the order of these steps. First is visual acuity testing, followed by gross examination, evaluation of extraocular muscle movement or EOMs, determination of the intraocular pressure or IOP, and lastly, the fundal examination. Let's start first with the history. So the history could be divided into this outline. Let's start with the demography. You need to ask for this, the basic demographic data, age, gender, including race maybe, but mostly Filipino, geographic location or residence, occupation, as well as socioeconomic conditions. So, question, do your geographic location and socioeconomic conditions affect your vision? Well, yes. So there's a study comparing those children raised between urban and rural populations, and they found that those children living in urban areas have higher rates of myopia. More of them need more eyeglass use because vision is both genetic as well as environmental. Depending on where you were raised and whether you had a lot of outdoor space growing up, it's going to affect whether you're going to have clear vision later on. Next, of course, you ask for the chief complaint. Is the chief complaint blurring of vision? That's the most common one, right? But there are many other associated symptoms we're going to tackle later on. Of course, you need to properly label the laterality. Is it the left eye or the right eye? Or is it both? Next, you ask for the duration. Has it been happening for a long time? Did it happen suddenly? Is it episodic? Does it happen only on specific times? If so, what are the triggering factors affecting them? Right? Of course, the severity. How blurred? Can you see just a pinpoint? Or can you see, or is it just generalized blurring? For the course, you need to establish the temporal relationship. What happened first was the first symptom that happened. And of course, you need to ask for any associated symptoms. For this, there may be eye pain, redness, discharge, headache, dizziness, or trauma. To complete your history, you need to ask about other systemic problems because this could also affect vision. So what are the diseases that affect vision as well? So these may be vascular diseases. For example, atherosclerotic cardiovascular disease. And related to that, some chronic conditions such as type 2 diabetes mellitus as well as hypertension. Okay? You may also note some brain tumors. For example, a pituitary tumor may involve a visual field cut. What type of visual field cut we're going to learn later on. And lastly, endocrine diseases. For example, hyperthyroidism. Patients with thyroid problems may have goiter, which is an enlargement of the thyroid gland, thereby appearing as an enlarged neck. Next, you ask for the treatment history. Are they taking any medications? So, some time ago in the Philippines, there was a fake news that urine could help for whatever reason. So, you need to elicit everything, including breast milk or herbal supplement medication. Now, you need also to ask for anti-TB medication. Why? Because ethambutol is known to cause optic neuritis. And as you know, many people in the Philippines have tuberculosis. Okay? Also, you need to assess compliance of patients to medication because it may affect whatever medication you prescribe to the patient later on. You need to assess the response, including complications. Of course, you need to ask as well if there has been any prior injury or any surgery, especially those done to the eye. You also need to ask for travel and migration history because there are certain infections that are not native to the Philippines. Okay? If you're suspecting infectious disease, you also need to elicit exposure to risk factors. For example, leptospirosis is of course associated with flood wading. For tuberculosis is of course associated with household exposure. And also, you need to ask whether they wear corrective lenses or eyeglasses. Because sometimes, the patient would come in wearing contact lenses, so you're not aware immediately what's the actual problem. Here are the common ocular signs and symptoms I would like you to know. There are 5 here. Disturbances in vision. You could also call it blurring of vision, but as you will see later on, there are many possible disturbances, not just generalized blurring. Next would be irritated eyes. It may appear as a red eye, headaches, masses, and deviation. Let's start with disturbances in vision. So what are the types of disturbances in vision that you could encounter? Of course, it could be blurring in vision. So the most common one would be lack of myopia. So parang may nakatabing sa mata, parang may plastic labo sa harapan, no? Just generalized blurring. Tapos pero pag nilapit mo yung bagay, for someone na myopic or nearsighted, biglang lilinaw. Kabaligtaran naman kapag hyperopic or farsighted, yung malayo yung kanya nakikita. But there are some conditions like in glaucoma wherein it's like tunnel vision. There is blurred periphery but a clear center. Okay? Next, there could be field cuts. Field cuts means may portion na yung field of vision na blind, na wala ka nakikita. Halimbawa, pwede sa tagiliran kapag tumor sa optic chiasm. So, paano malaman kung ano yung affected na field cut? Well, you need to know the neural pathway coming from the eyes to the occipital lobe where vision is processed. We're going to discuss that later on. Okay? So, for field cuts, your vision may be 20/20, but it looks like looking into a telescope. This one is different from tunnel vision. It's more of telescopic vision. Right? Next, there may be flashes and floaters. Pag sinabing flashes, may nakita po ba kayong mga kumikislap-kislap, no? O pwede nasabihin parang bituin. So, this symptom is called photopsia. It's a common complaint of patients with retinal detachment. So, this one is dangerous and needs immediate treatment. Last would be floaters. Floaters, may nakita po ba kayong palutang-lutang sa inyong paningin? So, it's normal. This one is more normal. Sometimes. But what you need to elicit is that, has the number of floaters been increasing in the past few days? Okay? Has there been an abrupt change in the number of floaters? They are called floaters because they float around the vitreous humor. This is seen among patients with posterior vitreous detachment or intermediate uveitis or secondary to inflammatory cells, meaning you have an infection of your eye. Now let's look at some figures to illustrate some of these disturbances in vision. On the left, you have normal vision. If you have a refractive error like myopia or hyperopia, you may see something like this. This one is astigmatism. So normally, you would see you wouldn't see any of these. No? So parang may kumakalat or nagbi-bleed yung liwanag. No? Parang nagsisparkle. So astigmatism causes problems with driving, especially at night, because the lights look like this. This is what I have been saying. There may be peripheral vision loss. It could be due to glaucoma. Okay? And this one is visual field cuts. Hemianopia. Hemi means half or kalahati. So here, nawala yung kalahati ng kanyang paningin. And there are many different types of field cuts. We're going to discuss this in the next figure. Carefully asking about the field cut could help elucidate and localize the lesion. For example, let's start by tracing the pathway of light or the pathway of vision starting from the eyes. So for example, magsisimula siya papasok dito sa iyong mata. And take note, nakabaligtaran siya. Halimbawa, yung bagay nasa kanang side ng iyong mata, marireceive siya sa left side ng iyong retina, di ba? And another thing is that depending on which part of the retina the stimulus comes from, it would differ in its path. For example, yung mga bagay na nasa left side na na-receive, yung vision na na-receive sa left side ng retina must travel towards the left side of the brain. So for example, meron ko nakitang bagay sa right, di ba? Tapos pumasok sa left side ng retina. Yung nakikita mo na nanggaling sa left side ng mata na nasa left retina as well would travel on the same side. However, yung mga nandito sa nasal side, no, ng retina ay papasok at magko-crossover in the area called the optic chiasm, which is located near the pituitary gland. Right? So you have your nasal and temporal retina. Nasa gitna ba o nasa gilid ng mata? Right? So, for example, let's look at the different types of field cuts, also known as blind spots or scotomata. If you have complete lack of vision in your right eye, then your problem is with the optic nerve on the right. Because the bundles coming from the right side of the eye are still together, right? Okay? Next, paano naman kung yung visual field cut mo ay tinatawag nating bitemporal hemianopsia? So wala ka nakikita sa gilid mo. Here, the problem may be in the crossing over at the area of the optic chiasm. Chiasm, coming from the Greek letter chi, which looks like a letter X. Ang problem kasi doon, minsan may mga pituitary tumors na kapag lumalaki, pwedeng naiipit niya yung area na yon. Next, how about if you have left homonymous hemianopsia? Okay? Meaning you don't see things on the left side of your field. There, the problem could be here in the optic tract already because nagkaroon na ng crossover. Right? So you have problem receiving stimulus from the right side of your retina, whether it's in the right temporal retina or in the right nasal retina of your left eye. Okay? And then, towards the back, towards the occipital area, it divides further into two. So this area is called your optic radiations. Optic radiations could be more parietal, so going upward, or more to the sides. Okay? So what you just have to remember is that if you have a blind spot, the lesion is located opposite to it. So halimbawa, kapag yung blind spot mo ay dito sa upper 1/4 or tinatawag nating pie in the sky, then your lesion is in the lower part in the temporal optic radiations. And also, because the pie in the sky is located in the upper left, then your lesion is going to be located on the right. Okay? How about if your lesion is in the parietal optic radiations? Then it's going to be located here on the lower half. So it's going to be called pie on the floor. But of course, the medical terms are left upper homonymous quadratanopsia and left lower homonymous quadratanopsia. Next, to continue with our lecture, these are flashes or photopsia. May nakita po ba kayong umiilaw-ilaw o kumikinang? Here, these are floaters. This could be normal, but depending on the other complaints, the temporality, so you need to ask the complete history to determine whether this is actually normal or pathologic. Now, let's move on from complaints in vision to irritated eyes. Irritated eyes could be what we call red eye, right? Or it could be painful. Now, there is a difference between stinging versus pain. Stinging could be experienced secondary to a foreign body sensation, parang nakapupuwing, or there could be pressure on the eye. On the other hand, pain is more of a throbbing, parang pumipintig sa iyong mata. Okay? Aside from that, you could have watering or discharge, naluluha. Okay? So if you have a red eye, there may be many reasons, right? But if it's relatively painless, there's no pus, you need to clarify whether it is viral or allergic. If it's more itchy, it's going to be allergic. Kapag naman may nana, pus, any discharge, it's going to be more likely bacterial in nature. Next, headaches could be associated with errors of refraction. But take note that there is a chain of referral for headache symptoms from opta to ORL to neurology. First, of course, if it's just a problem with an error of refraction, then you would need eyeglasses. So therefore, you need to look first for ophthalmology. Then ophthalmology is going to refer you to the optometrist para sukatan ka ng salamin. And the headache associated with the error of refraction is usually located temporally, but sometimes it will migrate to the occipital region. So if there's a problem with the error of refraction, then you need to refer to ENT later on and then to neurology to look for any other etiologies. You could also look for masses or tumors. Masses or tumors of the eye could be located periorbital, extraocular, or intraocular. Ocular means inside the balls of the eye. So periorbital means around this area here. Okay. So what are the telltale signs of an intraocular mass? So look at this example here. This finding is called a cat's eye or leukocoria. So normally, what we have is a red-orange reflex. That's why sometimes when you take pictures, you get a reddish reflection in your eye. But in contrast, this baby has a whitish reflection. This could be the telltale sign of a tumor called a retinoblastoma. So because the tumor is deforming the retina, this causes an abnormal reflection of the flash of the camera. So it appears white instead of red-orange. And lastly, there may be deviations. So when we say proptosis, it's a general term meaning a displacement forward. Exophthalmos refers specifically to the eyes. So when could we see those symptoms? You could see them in thyroid disease as well as if you have a tumor located behind the orbit. So it's called a retrobulbar mass. There may also be motility problems. Esotropia means the eyes are deviated inwards, while exotropia means the eyes are deviated outwards. Let's look at some figures. So this is proptosis or exophthalmos coming from thyroid disease. And as you could see here, there is what we call a scleral show. So normally, your eyelids should be covering a portion of your, or should be reaching up to a portion of your pupils, or yung itim ng mata. But here, yung puti ng mata, the sclera is showing a little bit. And lastly, this is one is called lagophthalmos. Lago comes from hair, no? Or parang kuneho, because hairs are believed to sleep with their eyes open. But for this one, the particular reason is because the patient has exophthalmos. That's why the eyelids are not closing properly. Let's now proceed to the 5 parts of the basic eye exam. The first of which is visual acuity. So what are you going to ask for in visual acuity? You're going to ask, is there any blurring, field cuts, flashes, and floaters? But in terms of the physical exam, what are the tools that you could use? The most commonly used is, of course, the Snellen chart. Okay? So in the Snellen chart, it may be expressed in terms of metric or feet. So the one that we use in the Philippines is mostly feet. But of course, you're going to encounter in some clinics the metric system. You're most familiar with the letters, right? But you could also be a tumbling E. So the E is moving, no? So the patient should be able to say, ano po bang direksyon, no? Taas, baba, kaliwa, or kanan. For some illiterate, for example, young children, you could also use animals. Okay? And there's a version as well that's used in numbers. Okay? So, aside from that, you could also see this, which is called an early treatment diabetic retinopathy study chart. It's the same number of letters per row, around 5 letters per row, unlike the Snellen chart, which has an unequal number of letters, right? So in the Snellen chart, there's only one big letter, but here you could see there are the same number of letters, 5 per row. Aside from that, there's equal spacing of the rows on a log scale, equal spacing of the letters as well. And the individual rows are balanced for letter difficulty. Okay? So when is it used? It's used in the glaucoma clinic. So this one is for subspecialists. So these are the different ways to express visual acuity. It could be English, metric, decimal, or logmar. But the one that we use most commonly is English notation. But I'm also going to teach you the metric notation because it's similar in principle. So visual acuity is expressed in two numbers, the numerator over the denominator. The denominator is the distance with which a normal person can see. The numerator is the distance with which the patient can see. So for example, if your vision is 20/20, the patient could see at 20 feet what a normal person could see at 20 feet. Okay? So how about for 2200? It just means that your patient could read at 20 feet what a normal person could read at 200 feet. So meaning, their vision is poor, right? They have poor visual acuity. How are we going to write this in the chart? We have this notation. VA means visual acuity, of course. Then we have Latin terms. OD means oculus dexter, meaning right eye. OS means oculus sinister or left eye. SC means sans correction, meaning you're not wearing any eyeglasses, and of course that's what you're interested in. Sometimes you could indicate there further CC, meaning corrective lenses, and CCPH, or corrective lenses with pinhole. So for example here, it means here pinhole, meaning without eyeglasses, their vision is 6/12. But if they use a pinhole, if the person sees through a pinhole, then it corrects up to 677.5. And there's another column here, and it stands for near vision. Near vision means that the patient can see up to the fifth line of the Jaeger chart. Later, we're going to see what the appearance of the Jaeger chart is. So how do we practically measure the distance visual acuity? Distance visual acuity is different from the near visual acuity that we're going to discuss later on. So first, papatayin mo siya 6 meters or 20 feet away from the Snellen chart. Then instruct the patient. Remember that vision is assessed one eye at a time. So you ask the patient to cover one eye. So what are the instructions? The hand should not be pressing on the patient's eye. Also make sure that they are not peeking through their fingers. Okay? So, ang sasabihin sa pasyente, pakibasa po simula sa taas, pababa. So, okay? So, the patient will start reading, di ba? Tapos, baka dating siya sa point na malabo na nakikita niya. So, sa isang line, halimbawa, na may 5 numbers, 5 letters pala, pwedeng 2 lang doon ang nababasa niya. Okay? But, so what is the valid measurement? The valid measurement is the smallest line that the patient can see well with a maximum of 1 mistake. So for example, if the patient already sees 2 letters incorrectly in that line, then that's not already a valid measurement. So for example, if the last line that the patient could read is 4 letters out of 5, then you take it as 4 out of 5. You could note it in your chart that the patient could read out of 5 letters, 4 of them properly. Okay? Okay. So, what if the patient is unable to read the biggest letter? Then you ask the patient to approach the chart 1 meter at a time. Okay? Ulitin ko ha, pag hindi nababasa ng patient yung pinakamalaking letter, ask mo palapitan 1 meter at a time until the patient is already 1 meter away from the chart. So this time, instead of the denominator changing, then the numerator is the one that's going to change, right? So, instead of 6 meters, it's going to change up 5, 4, and onwards. Okay? But if the patient at 1 meter is still unable to read the biggest letter, then you should proceed to finger counting. How is finger counting done? Let's look at the next slide. In finger counting, simple lang. Ilan po ba ito nakikita nyo? No? So the patient should be able to properly report it. So if at 3 meters, 3 feet or 1 meter, hindi pa rin nakikita ng pasyente, ikaw naman lalapit. lalapit ka up to 2 feet, 1 foot, and eventually up to 6 inches away. If until 6 inches, hindi pa rin niya nakikita, then you are going to proceed to the next portion of visual acuity assessment, which is hand movement. You're going to record visual acuity as counting fingers at a certain distance. Kung saan man pinakamalapit na nakikita ng pasyente mo or pinakamalayong nakikita ng pasyente mo. How about if there are some visual field cuts, for example, a patient with severe glaucoma. Halimbawa, tinanong mo, ilan po ba ito? Tapos ang reaction ng pasyente, gumanon siya, tumagilid. It's because they could only see at that certain visual field. Then you're going to report counting fingers 6 inches, temporal only. Meaning there's a nasal field cut. Right? Now let's look how hand movement is assessed. Next is hand movement and light projection. Take note, hand movement is always done together with light projection. Okay, so how do we do hand movement? At a distance of less than 1 feet, wave your hand in front of the patient. So tanungin mo lang, nakikita niyo po ba yung kamay ko? Ginagalaw ko po ba yung kamay ko? And make sure that you have to move your fingers in a way that no sound or air is perceived. Because you want to test vision. Okay, next, if hand movement is perceived, then you determine light projection by shining a light from all 4 quadrants. So ito, nakita niyo po ba yung ilaw? Okay, so if hand movement is positive, then you just record the response as HM. Next, how do we do light projection? In light projection, you have 4 quadrants, and you simply ask the patient to point to the direction of the light source. Ito, nakikita niyo po ba yung ilaw? Pakituro nga po kung saan. So it's called good light projection if the patient is able to identify the light source in all 4 quadrants. Fair if only 2 to 3 quadrants. And finally, poor light projection if only in 1 light quadrant. So for example, if it's advanced glaucoma, some patients may only identify the light from only one temporal side because of the severe field cut. Okay? And also, temporal light projection is usually the last one to go. And lastly, if the patient is still unable to identify the direction of the light source in light projection, we're going to proceed to light perception. So how is it done? Okay? You shine the light directly in front of the patient and determine whether they could detect the presence of light. So tanong mo lang, may nakita po ba kayong liwanag o wala? Okay? So if it's positive, then it's called LP. If there's no light perception, it's just right, NLP. Okay? Okay. And of course, you should be doing this in a dark room. Okay, so to summarize, how do we test distance visual acuity? We have these 5 steps. First, Snellen chart. If the patient is unable to see up to 3 feet, then proceed to counting fingers. If up to 1 foot, the patient is unable to see, then proceed to hand movement with light projection. If the patient is still unable to see at that point, then you could proceed to light perception or no light perception. Next, how about for pediatric patients? So all of that visual acuity testing we have been discussing up to this point has been for patients who are able to follow instructions. For pediatric patients, you have to disguise your physical examination as play. So you could use alternative charts like I have mentioned, animals, or if the patient is not yet familiar with letters but already familiar with numbers, you could use numbers. Aside from that, you could also do finger or hand play. You would ask the child to imitate what you do with your hands. But still, you test one eye at a time. Okay? For infants who are not verbal yet, you could use passing lights or brightly colored objects. So, what are some of the things that you could write in your chart? You could write there, able to track objects. If the infant is following the movement of the brightly colored object, you could also write fixes and follows. Pag tinititigan naman ng baby, yung pinapakita mong gamit, yung either liwanag o yung bright object, you could write central steady gaze maintained. Right? So what are the signs that the infant has poor vision? You could possibly note nystagmus. Nystagmus, there could also be misalignment of the eyes. Okay? So for newborn to 6 months, you should check if the eyes are already central. Central meaning the eyes are not deviating outwards, called exotropia, or inwards, called esotropia. Also, note if it is steady, meaning there are no jerking movements, also known as nystagmus. There are many directions of nystagmus, right? It could be rotatory or pendular. Okay, and you should also see if it is maintained, meaning even when one of the eyes is covered, the baby still fixates on the object. Okay, so central, steady, and maintained. And lastly, fixes and follows, meaning if 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 you move the object, the head or even the eyes of the infant should be able to follow that. But make sure that there are no other stimuli that could be taking away the attention of the baby. For example, you're not in a noisy environment. So how would you write that in the chart? You just write central, steady, maintained, fixes and follows. Right? For children who are slightly older, for example, toddlers and preschoolers, this is what I have mentioned. Aside from animals and numbers, you could also have shapes if the patient is already familiar with shapes. Okay? So that is distance visual acuity testing, both for adults and for pediatric patients. There is also near visual acuity testing. And take note that you only do this for patients who are 35 years old and older, because you're assessing for presbyopia, meaning age-related loss of visual acuity. And of course, you could do this for younger patients if findings suggest a near vision loss. Okay? Unlike distance visual acuity testing, near visual acuity testing is done binocular, meaning both eyes are open. Okay? And also, the patient should be wearing their reading glasses if they need it. So how do you do it? You ask the patient to hold the chart 14 inches or 35 centimeters away from them. And you record both the size and the distance. So for example, if the patient could read J5 up to J5 at 14 inches, then you write J5 at 14 inches. What's J5? It's here. You look for the Jaeger column and it's up to here. Meaning the patient could read up to these numbers. Right? Okay. So we're done now with visual acuity testing. Let's proceed now to gross inspection, which is the second step of the basic eye exam. Gross inspection, meaning you look for the gross features, meaning those you could see with the naked eye. So what are you going to check for during your gross inspection? Of course, it involves inspection as well as palpation. So you're going to inspect the upper and lower eyelids as well as the surrounding tissue and the palpebral fissure. We're going to check if there's any redness, masses, hemorrhages, abnormal pigmentation in the eyelids or the periocular tissues. During your palpation, of course, the eyelids should be smooth and the eyelashes should not touch the eye, meaning the eyelashes should be directed outwards. Because there's a condition we're going to see the figures later on in which the eyelashes are directed inwards and it's actually dangerous. So the limbus, which is the border between the itim ng mata and yung puti ng mata, the cornea or the pupil as well as the sclera, is 1 to 2 millimeters of the superior limbus should be covered by the upper eyelid. Otherwise, there may be either lid retraction or proptosis. The eyes are bulging outwards. Okay? And of course, you should always check for symmetry. So let's look at some conditions. We have a set of figures here. So dermatochalasis means the eyelids are drooping. So in this case, it's due to old age. It could also be secondary to severe weight loss. Next, this is either chalazion or hordeolum. Okay? Hordeolum is sty or culitate, meaning bacterial infection. While chalazion is a blockage of the meibomian glands or the oil glands. So we're not sure, depending on the other symptoms of the patient, whether this is chalazion or hordeolum. Next, this is a syndrome manifesting with various eye findings. So letter A is blepharophimosis, meaning narrowed horizontal dimensions of the eyelids of the eyes. Okay, or the palpebral fissure. Okay, there, it's narrowed. Second is ptosis or drooping eyelids. C is epicanthus inversus, meaning the folds of the eye are reversed. So instead of like this, the palpebral, the epicanthus of this patient is like that. And lastly, we have telecanthus or hypertelorism. Parang mata ng isda, magkalayo yung mata. So, widen distance between the two eyes. Alright. And lastly, this is trichiasis. Here, this is trichiasis of the lower eyelids, while this is trichiasis of the upper eyelids. So, it's dangerous because the eyelashes are going to cause abrasion of the eyes. Especially, what we fear is abrasion of the cornea. Because the cornea is an avascular organ, meaning it doesn't heal as much. So once it's abraded, then that may be permanent. That may cause permanent loss of vision. Right? Okay. So to summarize, so dermatocalasis is excess skin. Chalazion versus hordeolum is stye or kulite in our language. So in ptosis, it means drooping eyelids. So the vertical dimension is narrowed. In contrast, blepharophimosis is horizontal narrowing. Entropion means eyelashes directed, or the eyelids are folded inwards, while ectropion means the eyelids are folded outwards. Okay, and next you look into the eyelashes. This trichiasis means there is an extra row of eyelashes. Trichiasis means the eyelashes are growing inward. So what's the normal number of lashes? Usually only 3. 3 rows up and 3 rows down. Okay. So with gross inspection, you move from outside findings inward. Okay. So after looking into the palpebral fissure, we move into the eye itself. Next, we're going to tackle the different types of red eye. Okay, let's look at this figure here. This one looks scary, but it's actually relatively benign. So this one is what we call subconjunctival hemorrhage. So the different types of eye redness depends on the location of the redness itself. So this one looks relatively opaque, right? And you do not see any blood vessels here. Right. In contrast, in this one, this is a type of conjunctival congestion. So here, the redness is toward the fornices. Okay? So next, after you have identified that this is conjunctival injection, you need to identify next the type of etiology that caused this redness. So it could be either bacterial or viral or allergic. But here, we already know that it is bacterial because of the pus here. So pus is suggestive of a bacterial infection. Next, so how about if the redness is towards the limbus? It's called a ciliary injection. Right? So let's look at the next figure to try to identify the differences. So with conjunctival injection, the vessels are superficial and they are brighter red because they are superficial now. So located towards the edges or the so-called fornices, and it fades towards the limbus. Okay? And the branching is dichotomous, meaning it branches into twos. In contrast, in ciliary congestion, the vessels are deeper and are located more towards the limbus. Right? Aside from that, we have to clarify the type of discharge. So it could be either watery or white. If it's watery, there are two types there. So it could be either viral or allergic. If there is intense itchiness, then it's going to be more allergic. Right? So if there is whitish discharge or pus, that's going to be more likely bacterial in nature. And lastly, if the cornea becomes hazy or opaque, this one is a finding called corneal clouding. Okay? So let's move further inward. After that, we're going to look into the conjunctiva and the iris. So for conjunctiva, we've already learned that there may be different types of eye redness. For the cornea, check if it's clear or if there is any corneal clouding. The next structure is the iris. The iris is normally not smooth, so it should really naturally have its crevices, also known as the crypts. And actually, if you have a smooth iris, it could suggest a chronic uveitis. Remember, the uvea, also known as the vascular layer of the eye. Okay. Also, if the iris is velvety smooth, it could be a sign of inflammation. Specifically, what type of uveitis? Anterior uveitis. Because the iris is located in the anterior portion of the uvea. Okay? Okay. So what is this? What's the abnormal finding here? It's actually this. This is the arcus senilis, or this is a layer of fat that has been deposited due to old age. And next, what's this? This is a Kaiser-Fleischer ring, a deposit of copper that's coming from a metabolic derangement called Wilson's disease. Next, you may also see what's called Krepis or Busacas nodules. Busacas nodules are located on the surface of the iris. Nasa ibabaw siya. In contrast, Krepis nodules are located here at the pupillary margins. Right? So when do we see these findings? Many, but for the Philippines, we usually see it in tuberculosis. Okay? Next, what's this? This is iris depigmentation. So all of these areas here are depigmented, meaning the color has been stripped away from them. What is this? This is uveitis. And because of that, because of the inflammation of the uvea, here, the opening, the iris, has been misshapen. Aside from that, you can also see a layer of inflammation, and we call that hypopyon. That's a layer of pus. Right? Lastly, we have this figure. This is called iridodialysis, meaning the iris has been detached from its attachments. Right? Here. Alright. That's it for the iris. Let's now proceed next to the pupils, which is the last portion for the gross eye exam. So when assessing for the pupils, you ask the patient to look at a distant object. So tingin po kayo sa malayo. So if merong orasan doon sa malayo, ituro nyo yung patient na tumingin doon. Next, you assess the patient's size, shape, and symmetry. Of course, the pupils should be equal, round, and briskly reactive to light. So write it in the chart as pupils equal, round, reactive to light. Okay? So the normal value should be, the eyes should be around, or the pupils should be around 3 to 5 millimeters in size. Otherwise, it's dilated, and otherwise, it's constricted. Okay? So, okay. So, normally, the pupil should be accommodating, meaning if you put an object closer to the eyes, it should be constricting to focus on the nearby object. Aside from that, it should also be responding to light, meaning it should be controlling the amount of light entering into the eye. So, in other words, if you shine a light directly to it, then it should be constricting. Okay? Okay. So, the response to light is twofold. So, there is a direct response to light and a consensual response to light. What does it mean? So, direct response to light, meaning if you shine a light to the right eye, then the right eye constricts. Consensual response means if you shine a light to the right eye, then the left side should also constrict even if you are not shining a light to it. And the normal response, of course, is that it should be equal and synchronous. Okay? So, how do you do the swinging flashlight test? Here. So, first you shine a light to one eye, then you swing it to the other eye, and do it again. Okay? And of course, you should look one eye at a time. So, you should look for that direct response to light to the right eye, and then the consensual response. Okay. What are some of the abnormalities that you could detect there? You could detect a relative apparent pupillary defect or a Marcus Gunn pupil. Right? Okay. So this is mediated, by the way, by the cranial nerve 2 as the afferent arm, meaning going towards the brain, and the cranial nerve 3 or efferent arm. Okay? So depending on the response of the eye, you could identify whether the problem is a problem with the cranial nerve 2 or the cranial nerve 3, either ophthalmic or oculomotor nerve problem. So for example, if there is a dilation of the pupil when the light is shown on the affected eye, instead na mag-constrict, nag-dilate, that's called paradoxical dilation, then you know that there is a problem with the ophthalmic nerve of that eye. So for example, if you shine a light on the right eye, and instead of constricting, it dilated, then that is a cranial nerve 2 problem on the right. In contrast, if you shine a light on the right eye and it dilated, and then you also shown a light on the left eye, but still the right eye is dilated, meaning both direct and consensual reflexes are affected, then that is a cranial nerve 3 problem on the right. So in this video, you could see how the swinging flashlight reflex is done. Right? Okay, so that's it for the gross eye examination. Now let's proceed to the evaluation of the extraocular muscles or EOMs. So we're here now. Third part of the basic eye exam. So how are we going to assess whether there is a problem with the extraocular muscles? One of the ways you could do that is through the corneal light reflex. For this, you need the patient to be in primary gaze. So the patient should be looking straight forward at a distant object. So just ask the patient to gaze ahead, then you use your pen light to shine directly on the center of each eye. Okay? So if, for example, so normally, the light should be shining directly on the pupils. Should be reflected back directly on the pupils. However, if it's yung kinang ng liwanag ay nandito sa kaliwa, nasa outward na part, then the eye is deviated inwards. So that's called esotropia. Okay? The counterpart is if the eye is deviated outward, it's called exotropia. If it's deviated upward, it's called hypertropia, and if it's deviated downward, it's hypotropia. So it's simple, right? The reflection is just going to be located opposite to the deviation. And can you quantify this? Yes, it's what we call the Hirschberg reflex, and the position of the X mark if it's in the pupillary border, then the grade or degree of deviation is 15 degrees. If it's located in the iris, it's 30 degrees. If it's in the limbus, it's 45 degrees. And if the reflection is located in the sclera, the deviation is 60 degrees. Alright? So let's look at an example. Here, the patient is looking directly forward. The reflection is here located in the pupil. So this is going to be 15 degrees left, esotropia. Right. How about for this patient? For this patient, the reflection is still located here in the pupil, right? So it's still 15 degrees left, exotropia this time because it's directed outwards. Okay. So after that, after the Hirschberg reflex, we could test for the extraocular muscle movements. So for this, you ask the patient to follow an object, so either your finger or your light, and then you check the 6 cardinal directions of gaze. So in checking it, you could either do an H shape, H, or X. Okay? So there are two types that you have to test. Duction, meaning both eyes. Duction, dalawang mata. So, mali nakalagay sa PowerPoint, no? Paki-correct na lang. Duction, both eyes. So, nakadilat, parehong mata. Version, one eye at a time. Right? So, by the way, which cranial nerves are handling which extraocular muscles? So, our mnemonic is this: LR6, SO4, AO3. Meaning, for the lateral rectus, the one responsible for that is the cranial nerve 6 or abducent nerve. Okay, for the superior oblique, the one responsible for that is the trochlear nerve or cranial nerve 4. For the rest, for all of the rest, It's the oculomotor nerve or cranial nerve 3. Okay? So, in order to know which nerve or which muscle is affected, you have of course need to be familiar with the anatomy. Okay? So just memorize this. You have encountered this for sure already in the anatomy of the eyes. Okay? Medial rectus, lateral rectus, superior rectus, inferior rectus, inferior oblique, superior oblique. Okay? So how are you going to report your findings in the medical chart? If you have full extraocular muscle movement, then you write the bars and then you write the arrows na sagad. No? Pag limited, for example, pag limited yung left eye, hanggang dito lang. Okay? Ayan. So lastly, after extraocular, next part of the basic eye exam is the intraocular pressure determination. And for this, we use a method called digital tonometry. In other words, you estimate the intraocular pressure using your digits. No? So, sige. The normal intraocular pressure is between 10 to 21 millimeters mercury. And the normal difference is between 2 it should be around 2 millimeters mercury. So, the common way that we assess intraocular pressure is just digital or finger tonometry. But of course, if you rotate in ophthalmology, they have different tonometers there. You have the Schotz tonometer, also known as the indentation tonometry. However, because you actually apply a contact to the pressure, contact to the eye, you cannot use it for corneas, for certain damaged corneas. The gold standard for tonometry is called a Goldmann or applanation tonometry. And lastly, we have non-contact tonometry. Non-contact tonometry is for uncooperative or difficult patients. So how do we do digital tonometry? Let's look here in the next figure. So how do we do digital tonometry? So of course, you need to brace yourself on the patient's face, just so you don't apply too much pressure on the eyes. So you just do this. Pindut-pindutin lang. You just use your two fingers pressing alternately on the eye. But of course, you should not do this maneuver if you suspect perforation or nabutas yung mata. Okay? So how do we grade it? You could grade it as either soft, hypotonic, or firm. Okay? So firm is like the forehead, soft is like the tip of the nose, while hypotonic is like the lips. So the normal one is around soft. Okay. So lastly, we have fundoscopy for the basic eye exam. Okay? Do you need to buy your own fundoscope? Not necessarily, unless you want to proceed to either neurology or ophthalmology or otorhinolaryngology. Right? So right now, it's okay if you just share your materials. So there are two types of fundoscopy, either direct or indirect ophthalmoscopy. The one that we use is actually what we call direct ophthalmoscopy because it is easier to use, it yields a real and direct image, meaning not inverted. There is high magnification. However, there's a small field of view and it's just a 2D image. When you rotate in opta, they could do their indirect ophthalmoscopy. It causes better visualization, but of course, further training is required. Okay? So, what are the parts of the fundoscope? There's a doctor's view window. So you look here at the front, at the flat side, right? This one's the one that's facing your patient. There are adjustment wheels, both for refraction as well as for the aperture. Okay? You could watch a YouTube video here. The link is on the next slide. You could watch this to further learn how to do the ophthalmoscopy. So when you do the ophthalmoscopy, so ano yung makikita mo when you do fundoscopy? So yung unang makikita is of course the red-orange reflex, which is the reflection of the light back because of the retina. Okay? Aside from that, you should also check the media. Is it clear? Or can you see any abnormalities? Is it hazy? Okay? And next, what are you going to see? Is this the right or the left eye? Of course, this is the right eye because this is on the nasal part. Remember, the optic nerve is on the nasal part. Okay? So the fovea is the point of maximal acuity. While corresponding to the optic nerve, yung point kung saan lumalabas yung optic nerve is the blind spot. No? So wala kang rods and cones doon sa air na yon because doon lumalabas ang iyong optic nerve. Okay? So after that, what are you going to check next? You're going to follow the blood vessels towards the optic disc. And here you need to note the cup to disc ratio. Right? So the normal finding is that the cup, which is the inner part here, should be around 0.2 of the entire disc. Otherwise, it could be either smaller or larger than usual. So you see those abnormalities in glaucoma. So if you have increased intraocular pressure, eventually you're going to also have an abnormal cup to disc ratio. Next, what do you need to notice about the blood vessels? So question, which one of this is the arteries and which one is the vessels? So the arteries are narrower compared to the veins. So for example here, this is the artery and this is the vein. So the normal arteriovenous ratio is 2:3, meaning the arteries are around 2/3 of the width of the veins. Okay? So what are some of the abnormalities you could possibly note? There may be copper wiring or silver wiring. So you see this with long-standing hypertension. You could also see AV nicking, arteriovenous nicking, in which at the point where the arteries and the veins meet, they nick each other. No? Alright. You could also note any of these abnormal findings. So these ones are laser marks. That's why it's important in your history to ask whether they have been treated for any other ophthalmic condition earlier. This one, in contrast, are what we call hard exudates. This is called drusen. Okay. We're not going to discuss issue of this because there are too many. But you need to learn and be familiar with their appearance. And I have an atlas linked in our Moodle for you to self-study the different types of ophthalmic findings. Okay? So what are these? These are also laser burns or laser marks from ophthalmologic treatment earlier. So this one is toxoplasmosis and this one is syphilis. Okay. So in summary, when doing your fundoscopy, you need to check for the red-orange reflex. Is there a clear media or is it hazy? Next, examine the disc. The disc should normally be pink with distinct borders, and the normal cup-to-disc ratio is 0.2. Next, look at the retinal vessels, the arteries and the veins. The normal arteriovenous ratio is around 2:3, meaning the arteries are 2/3 of the size of the veins. Next, assess the retinal background. Are there any hemorrhages or exudates? Abnormalities there could come from chronic long-standing diseases such as hypertension and diabetes. And lastly, you check the macula last. So how do you check for the macula or fovea? You shine the light directly towards the macula or fovea. And dapat, kapag inilawan mo yon, magre-reflect back yung ilaw sa'yo, so ikaw masisilaw ka rin. No? So if nasilaw ka, that's called a good foveal reflex. Okay? So in summary, these are the findings in the basic eye exam. You note the visual acuity. This is the gross eye exam. This is the test for the intraocular pressure or digital tonometry. This is the test for the extraocular movements. And lastly, this is the test for your fundoscopy. Alright. So that's it. And let's proceed now to the examination of the oral cavity. This discussion of the oral cavity exam is going to be much shorter than the basic eye exam. So for this, I have divided our lecture into the anatomy, the examination for the oral cavity, the examination for the hypopharynx, and lastly, the reporting or how you're going to report this in the medical chart. Okay? So the oral cavity is still divided between inspection and palpation. There's no need for percussion or auscultation because you can do that with the oral cavity. Okay. For the hypopharynx, you do laryngoscopy. And it could be done either direct or indirect. Only the other one is done routinely in the oral clinic. And we're going to learn how to do it. Right? So now let's look at the anatomy. So there's a difference between the oral cavity and the oropharynx. Remember, the pharynx could be divided between the nasopharynx, the portion behind the nose, the oropharynx, the portion behind the oral cavity, and lastly, the hypopharynx, which is just above your larynx. Okay? So the parts of the oral cavity are as follows. The lips, the red part is the vermilion border, right? The gingivobuccal sinus is the fold between the gums and the lips. So, the gingiva is the gums, right? The floor of the tongue is also part of the oral cavity as well as the hard palate. Okay? Your teeth lie over the, over your gingivae. So, the oropharynx, once you reach the soft palate, that's already the oropharynx. The posterior 1/3 of the tongue is called the base of the tongue, and that's also at the oropharynx. The tonsillar pillars and the tonsillar fossa, where your tonsils are located, are also oropharynx already. Okay? So how do you do the oral cavity examination? For this, we have this YouTube video. Just please watch this on your allotted time. Right? There are three different scorings that we have to learn for the oral cavity exam. I'm going to go through them. First is the Friedman tongue position. So in the Friedman tongue position, just ask the patient to open their mouth wide and to keep the tongue inside the mouth. Okay? And then you're going to rate the uvula and the tonsils. One, if you could visualize most of the uvula. Okay? In 2A, if you could visualize most of the uvula but not the tonsils. 2B, you could visualize the entire soft palate up to the uvular base. 3, you could visualize most of the soft palate. And 4, if you could not visualize the soft palate anymore. So what's the importance of this tongue scoring? This has an impact on the difficulty of intubation. So for example, anesthesiologists do this prior to the operation in order to try to estimate how difficult it's going to be to try to intubate the patient. So if it's a difficult intubation, then they may ask for help from either their seniors or their consultants. Okay. Aside from the Friedman tongue position, there's another scoring called the modified Malampati. So the difference in the modified Malampati is you ask the patient to stick out their tongue. So again, the scoring is somewhat similar. If you could visualize the whole uvula, 1. If you could visualize most of the uvula, it's 2. If you could visualize the soft palate, it's 3. If you cannot visualize any of those, it's 4. Right? So this is in order of increasing difficulty of intubation. Okay? And lastly, we have a different scoring for the tonsils. Alright. So for this one, it's in terms of increasing largeness or size of the tonsils. So, if the tonsils are already near touching each other, these are already called kissing tonsils. Right. So, let's see how to inspect the oral cavity. If the patient have any dentures, you ask them to remove it. Then you retract the cheek and the lips using your tongue depressor. Okay. Sometimes in your hospital, they may be a metal tongue depressor, but of course it has to be sterilized in between patients. But for pediatric patients, you may use a wooden tongue depressor. You ask the patient to relax their tongue and depress the anterior 1/3. Take note, you're only depressing the anterior portion of the tongue because if you push the tongue depressor too much into the tongue, it's going to trigger the gag reflex. Okay? You could also ask the patient to move their tongue. When they protrude it, it should be protruding symmetrically. Okay? Then you could retract the tongue medially to visualize the retromolar trigone. Meaning, here, the portion that is behind the molars. Okay? You inspect all the aspects of the tongue, and you should visualize the tonsils, you should grade it, assess their symmetry, look into the pharynx, the tonsillar fossa, as well as the tonsillar pillars. Okay? After inspection, you proceed with the next step, which is palpation. What are the parts of the oral cavity you should palpate? You should palpate the temporomandibular joints. Then using a gloved hand, you could bimanually palpate. Bimanually meaning both hands. One hand inside the mouth, the other outside. One hand inside the mouth, the other outside. And then you palpate the buccal areas, the oral tissues, and salivary glands. If there's any pain, tenderness, or any masses. Okay? After the oral cavity, you next proceed to the hypopharynx. And for that, you need your laryngoscope. I mean your laryngeal mirror. Alright. So what's the proper positioning for the hypopharynx examination? The patient should be leaning forward with the neck slightly flexed. Then, instruct the patient to stick out their tongue. You should grasp the tongue with a gauze. And take note, you should avoid pressing the tongue against the lower teeth or the lower incisors. That's going to be painful. So you just pull straight outwards. Okay? And then you use your indirect laryngoscope. Take note, magkaiba yung appearance ng laryngeal mirror sa ginagamit for posterior rhinoscopy. Pag sinabing posterior rhinoscopy, yun yung likod ng ilong, di ba? So iba yung mirror na ginagamit doon. Yung laryngeal mirror is a smaller mirror. Magkamukha sila, but mas maliit lang yung laryngeal mirror. Okay? So you warm the laryngeal mirror by rubbing it against the inside of the cheeks. Why? Because if it's not warm enough, it's going to fog up if you stick it inside the patient's mouth. Then, you raise the soft palate upwards and you focus a light on the laryngeal mirror. If the patient is about to gag, instruct mo lang, hinga lang po kayo sa bibig. Instruct the patient to take a deep breath and say, "He." So, when the patient says, "He," then the vocal cords should be opposing. Okay? And of course, you inspect the vocal folds as they move. Are they moving completely? And then, aside from that, you also inspect the base of the tongue, the valleculae, and the laryngeal introitus. Take note if there is any pooling of saliva as well as any masses. With this video, you could watch it to observe how the indirect mirror laryngoscopy is done. Just take note that when you do an indirect mirror laryngoscopy, the image is going to be inverted, right? Okay, so what are some of the abnormal findings that you could see? There may be polyps there in the vocal cords. There may be nodules specifically for voice abusers, for example, teachers or barkers. There may also be one-sided paralysis. When the patient says he, this should be opposing. So for this, for example, then there is a right paralysis, right-sided paresis. Okay, cancer is of course going to be looking like this. Alright, so when you rotate to the oral clinic, you may be able to observe rigid video stroboscopy. Just watch it with this video. But the difference is just that there's a specialized device for visualizing the vocal cords. Okay? Alright. So how are you going to report your findings in laryngoscopy? Well, of course, you should be able to draw the oral cavity first. Okay? So there should be no lesions, masses, or discharge. The teeth are either complete and without caries. The tongue should be midline. Okay? And no fasciculations should be observed. Note the tonsils. Are they normal? If they are not normal, you should be able to grade them properly. Okay? Upon palpation, is there any crepitus of the temporomandibular joint? Are there any masses, tenderness? Are the salivary glands non-palpable? That's for the oral cavity. How about for the examination of the hypopharynx? So upon indirect laryngoscopy, you should be able to note the following structures, and you should be able to draw this. Right. So we're able to visualize the lingual tonsils, the epiglottis, and the vocal folds. Are there any masses? When you ask the patient to phonate, were the vocal folds moving symmetrically, and was there a full range of motion? Alright, and that's it for our lecture on the basic eye exam and the examination of the oral cavity as well as the vocal cords. Okay, so if you have any questions, don't hesitate to message me. Thank you very much, everyone.